One second. Um, so so thank you for everyone joining today. I apologize, my camera is not working for some reason. But so today and all of November is actually Diabetes Awareness Month. So that's why we wanted to specifically speak on this topic of how of in general diabetes, the knowledge of it, and kind of just the ins and outs and everything that we can take out of Dr. Escobar and Dr. Schick's minds right now about diabetes. So please have questions, but also just how mainly exercise can help with the effects and symptoms of diabetes. So I would like for both Dr. Schick and Dr. Escobar, both of you are very credentialed people, especially in the this field of exercise and medicine and just overall health. So I just wanted both of you to take a second and kind of list off your achievements and credentials. You guys have grinded so hard for so long to receive your accolades. So I definitely want to give you guys props for those. So just take a second for both of you and let us hear those.
I'm old. I mean, that's my biggest credential. That's the biggest reason you should listen to me, is because I'm old. I've just been through all of it, and I've seen most of it. I don't know what do you want me to say. I have a PhD in muscle metabolism, cell physiology. I like hormones. And let's see.
So what are some of your like favorite topics to speak on in general?
Anything endocrinology related, anything kind of like globally health related. I like studying pathophysiology of chronic disease, and when I was your guys' age, I was more in like the performance realm. So, I was really into like muscle science and performance science and exercise for performance, strength and conditioning and stuff like that. And then somewhere along the line, I don't know, probably like in my mid 20s, late 20s, I just got bored of it. And so I developed a more vested interest in looking at the diseased state and how physiology manifests itself there. And so that's what I chose to pursue for the rest of my graduate studies. And so most of my research revolves around that. So my most recent research projects revolve around the hyperglycemic state in and around exercise and the inflammatory response that goes into that. I also have looked at the menstrual phase. That's kind of the newest line, is looking at how metabolism is altered during menstrual phase and how menstrual phase affects exercise metabolism. It's an area of study that's woefully underrepresented in our current literature. So that's sort of an area of my interest right now, is essentially estrogen as a global mediator of metabolism.
I don't really hear a lot of research based around that. So it's awesome to hear that you're kind of heading that way right now.
Very little.
Yeah.
There's very, very little. I kind of like reached a point where, and Dr. Escobar may disagree. I don't know. I think Dr. Cotta would disagree. I find muscle boring. It's not super interesting to me anymore. I don't have any muscles anymore. So it's like, why the hell even bother? I'm much more interested in multi-system physiology. So I like renal physiology. I like liver physiology. I have a big interest in psychology, actually, neuroscience, neurobiology. And so that's actually the things I like to talk about. But yeah, that's pretty much it. I ramble.
Definitely. No, we love it. And thank you for sharing. Dr. Escobar, take the floor now.
PhD in exercise science, studied sports exercise nutrition during my early part of my grad studies. Probably like a lot of you are interested in, like Dr. Schick was interested in, like performance and things like that. But during my PhD at the University of New Mexico, got more into the cell physiology and some of the mechanistic stuff that relates to the adaptive responses to exercise and the role that affect health and disease. So I started studying autophagy. So if you've had me in class, you've heard autophagy about 1,000,000 times. It's a cellular recycling system that is involved with the positive response to exercise and implicated on like health status and disease status. But still do, a lot of applied exercise, performance-based nutrition type research. And then the other thing as well is, I did personal training essentially my entire adult life, except for the couple of years during my PhD. But all through my community college years, my undergrad, my master's, and even now, like that's where I'm at right now. But I work as a trainer. Currently, I'm working with older adults, some that have certain chronic conditions like type 2 diabetes or even type 1 diabetes. So, if you're in my class, you've probably heard me talk about a lot of different clients, a lot of different stories. So I try to marry and I try to communicate and tie the physiology, conceptual, fundamental textbook type stuff, the research to like applied practice and how you would work with someone with certain conditions and things like that. So I think this is a good topic to speak on. And I'm Mexican, so I got a lot of family that has diabetes. So
Yeah, I'm with you on that. Like, this is why I'm super interested in the topic as well. I'm also Mexican, and so this is something that's extremely prevalent in my life, and a lot of just like ethnic people's lives. We don't have a lot of knowledge based around diabetes and how to aid in those symptoms. But yeah, I'm so super glad that both of you guys are here today to speak on it. Um, and just so everyone else knows, this is going to be more of an open forum type of event. So if you do have a question, just say something in the chat or raise your hand with the like reactions in Zoom. So please feel free to let us know when you have a question. But to kind of start everything off, if we could just get a quick kind of intro into like what is diabetes. Are there multiple types of diabetes, or is one more severe than the other? One hereditary, is one not? Things along that nature, just to start off and get people's minds back into that, what diabetes is, if you do have knowledge about it, or if this is your first time hearing about things like that.
All right, do you want us to take turns like answering stuff, or how do you want this to work, Giovanni?
Yeah, we can take turns. We'll go by turns. So Dr. Schick, you can go first. Dr. Escobar, you can go next. Also, I mean, by all means, if either of you have to add something, just kind of jump in with each other. This is very conversational based. So
yeah, I think Dr. Escobar knows how I work anyways. He knows I'm super informal. So Dr. Escobar, if you have anything you want to add or clarify, you can just interrupt me. I really don't care. So the question was, are there different types of diabetes? There's a few different types of diabetes. There's probably what you're all most familiar with, which is type 2 diabetes, which is the sort of diabetes that has reached, epidemic levels in the last 35 to 40 years. And the incidence, meaning that the incidence of it has just skyrocketed since the late 70s. And it's continued to soar. I mean, it's like 9.5% of our population, I think, in the US is diagnosed as type 2 diabetic. And then there's like millions of other cases that are undiagnosed. And then there are cases that are considered more in like the pre-diabetic stage. So it affects, I would assume that type 2 diabetes affects every single person on this call, either like personally or like indirectly somehow. You either have like a sibling or a parent or a grandparent who has it. And the reason for that is that type 2 diabetes, although it can have a genetic component, it's largely a disease of lifestyle. It's largely a disease that kind of follows the coattails of being overweight and obese. So a lot of it come in the group that we're talking to right now is a nice group because talking about exercise as a medicinal source of therapy. So, that combination of poor diet and sedentary lifestyle, it really lays the groundwork, metabolically for setting somebody up for type 2 diabetes. So there's the type 2 sort of thing. And the interesting thing about type 2 diabetes is that it used to be called adult onset diabetes when you guys were little pea pods still. When you guys were like the size of like my forearm, it was called adult onset diabetes. That was what type 2 diabetes used to be called. And the reason for that is because it used to be the case that you didn't see type 2 diabetes in anybody younger than about like 45. The age of 45 was sort of like the line in the sand where you started to see this sort of diabetes where that person might have been overweight or obese through early adulthood, and then suddenly they've become insulin resistant, and then they're chronically hyperglycemic and they're getting all these complications. And those complications didn't really reach like a diagnostic threshold for type 2 diabetes until like mid 40s. But the wild thing is that we now see what used to be called adult onset diabetes in kids, like in, early adolescence or even, late primary school ages, like 10, 11, 12. And a lot of that is owed to the fact that being a disease of lifestyle, you can trace it back to the way that people are living. So it's like overabundance, and Dr. Escobar is a much better expert on this stuff. So I can kind of add little things here, but you can kind of owe it to overabundance of shitty calories everywhere on every street corner, and a lack of understanding that you have to move your body throughout the day. And on top of that, it's there's sociocultural things that go into it, but the basic premise is that culturally we've shifted into eating really, really poorly. We survive on quick calories that are cheap, and we're not active throughout the day. And it's not good enough to just to exercise 30 minutes a day. To be optimally healthy, most people have to be active throughout the whole day. You should be being active throughout the day. And so because we've shifted in the way that we live into this more sedentarianism and this sort of unhealthy diet thing, you're seeing type 2 diabetes in a very young age, which is really alarming. And I don't want to get off into any tangents, but which is what I do best. But part of the reason that exists is that it's not only that kids are accessing really shitty calories. It's not just that they're not moving. It's not just that they're playing video games all day. It's also because the preponderance of gestational diabetes has been on the rise for many, many years now. And so this will kind of dovetail into the next type of diabetes that I can mention, which is gestational diabetes. Gestational diabetes is a form of diabetes that frankly can affect any woman during pregnancy. And it usually comes about like in month 5, like around week 20 to week 24, I think, something like that. And gestational diabetes is a type of diabetes that, although any woman can get it during pregnancy, you're at a much higher risk for getting it if you become pregnant when you're obese, or even if you're just overweight, or if you're insulin resistant. So in the last 30 years, there's been this big increase in obesity, big increase in at least being overweight, poor diet choices. And so along with that, we've seen an increase in gestational diabetic cases. The mechanism of gestational diabetes is somewhat complicated. It mostly relates to the fact that the fetal placenta produces hormones that promote fetal growth, but those hormones also counteract maternal insulin, right? They counteract insulin that the mom is producing and that the mom is trying to use to regulate her own blood sugar. And so those hormones are like lactogen and cortisol and estrogen. They can cross the placental wall, and they can counteract the mom's own insulin so that the mom has less use of her own insulin and basically becomes insulin resistant for that certain time period during pregnancy. And usually gestational diabetes sort of like resolves itself after birth, but in some folks it lasts. And in some folks it can be really bad, where it can last and then become full-blown type 2 diabetes. And the extent of gestational diabetes, and what I mean by that is the magnitude of gestational diabetes. So just how hyperglycemic the mom becomes can be dependent on the nutritional state and metabolic health of the mom during conception. So if you're obese, overweight, sedentary, etc., you get pregnant, you're at a higher risk for becoming gestational diabetic, and you're at high risk for that gestational diabetes being really bad. And the reason that that's important is that, number one, obviously puts the mom at risk for diabetes during pregnancy and then also potentially afterwards. But there's evidence in the last, I'd say, 7 years, going back to my earliest knowledge would be 2012, about where excessive glucose exposure to the placenta can get inside the placenta and get inside the growing embryo and can cause hypomethylation of the DNA that is in the growing baby. And so that means that you're actually monkeying around with the genetics of the growing fetus. And so hyperglucose exposure to the fetus can cause problems with growth. So first and foremost, it can cause macrosomia, which is big fat baby. Everybody thinks that like big fat babies are cute, but they're not. They may be like kind of interesting, but big fat babies are a mark of disease. They are a mark that mom probably had gestational diabetes. The baby's now born with excessive body fat, was probably exposed to higher than normal levels of glucose because of gestational diabetes, and now is at risk for type 2 diabetes. We now have data clearly showing that the magnitude of gestational diabetes affects the susceptibility of the baby as it grows to getting type 2 diabetes early on, not when they're 45, but when they're like 7 or 8. And that's because of, again, this overexposure of glucose to the DNA inside the growing embryo and ultimately the fetus. And so you're putting the baby at risk for type 2 diabetes. You're also inhibiting the hypertrophic effect of that fetus to strength training. Interesting stuff where what's shown is that the babies that have been born to moms with bad gestational diabetes, they have a lower than normal hypertrophy response. Think about that. A lower than normal hypertrophy response. So like, I'm going to pick out a name here. I don't know Ryan Buckley, so I'm going to say Ryan Buckley. Ryan, wouldn't you be pissed off if all your friends around you were doing some new strength training routine and they were getting jacked, but you weren't getting as jacked, even though you were doing the same thing? You were eating the same things, you were lifting the same things, but your muscles weren't getting massive. Yet all your friends who were not taking steroids, let's take steroids off the table, everybody's getting jacked but you. Wouldn't you be pissed off? Ryan, I'm assuming you would be. You can either unmute yourself or chat, but I'm going to assume yes. Ryan says yes. Ryan is right. Ryan would be pissed, and I would be pissed too. And that's what we have data suggesting that high, very bad gestational diabetes can impede the hypertrophic response to the baby as it grows. So that's shitty, because what's one of the things we have to combat type 2 diabetes? Exercise. Well, now you're handicapping the effect of exercise on that kid. So it develops into really complex problems, gestational diabetes does. And I think
I got a question.
Oh.
I got a question. Can I ask?
Yeah, go ahead. Of course.
Does it affect the development of the just overall baseline lean body mass, or is it just a hypertrophic response, irrespective of lean body mass at birth or during development?
I don't have a great answer for that. I honestly don't know. What I know, I think you can probably presume that lean body mass is probably affected, that there is probably a preponderance of excess body fat as they grow. I don't know the data. I'm not familiar with the data on that. What I will say is that I feel like I haven't even gotten to the worst part yet, is that not only is the the fetus at risk for type 2 diabetes when it's born into a mom with gestational diabetes. Not only are they going to have a lower hypertrophic response to strength training type of exercise, but if a female fetus, and let me try to get this biology correct because it's been a long time since I've had molecular biology. And Dr. Escobar, you can jump in if I'm wrong here. The germ cell, right? The egg cell. Men don't have eggs. Women have eggs. That's called the germ cell. That's where certain types of diseases are passed on generationally through the germ cell, through the egg. So that means that there's a slew of chronic diseases that women are responsible for passing on generation after generation. And there are a slew of diseases that men are responsible for passing on generation after generation. So what we understand right now is that gestational diabetes leading to overexposure of glucose to a germ cell means that if you have a female fetus who has a mom who has gestational diabetes, and that female fetus's germ cell is overexposed to glucose due to gestational diabetes, hypomethylation of her DNA in her germ cell encourages generational pass on, meaning that if a mom has gestational diabetes and has a girl, she will now have a raised risk of passing it on through no fault of her own and no fault of her own kid that she might get pregnant with to her kid. So now you have generational diabetes that we start seeing sprout up due to gestational diabetes. It's not good. So that's kind of like the main thrust of the problem is that, you can talk about like curbed growth and curbed hypertrophy and all that stuff, but things get really insidious when you start talking about generational pass on. And it's so complicated to try to get ahead of. So type 2 diabetes, gestational diabetes, there sort of is a connection there. What I want to differentiate though, is those from type 1 diabetes. So, and I think I have a student right now who has type 1 diabetes, and anyways, type 1 diabetes is sort of a different animal from type 2 diabetes and from gestational diabetes. Type 1 diabetes is the type of diabetes where the symptomology might be similar to type 2 diabetes, meaning type 1 diabetics tend to be chronically hyperglycemic. They tend to have issues controlling blood sugar throughout the day. But the causation of type 1 diabetes is very, very different from type 2 diabetes. Whereas type 2 diabetes is largely, as we understand it today, a disease of lifestyle with sort of a genetic kiss to it, like a small genetic component, possibly. Type 1 diabetes is mostly genetic. Type 1 diabetes is sort of an unfortunate inherited disease where if you have a certain group of genetic markers that you've inherited and you're exposed to some environmental trigger, you can develop a situation where your immune system begins to attack the insulin producing cells of your body so that your body can't produce insulin, or so that it has a very lowered ability to produce insulin and use insulin. And so the sort of like the 10,000 mile view between type 1 and type 2 is that throughout the existence of type 1 diabetes, when you look at incidence rate, the incidence rate of type 1 diabetes has never really gone up throughout time. Throughout the 80s, 70s and 80s, 90s, 2000s, not really gone up. And that's because it has a genetic component, it's inherited, and it appears to be tied to environmental trigger that causes an autoimmune destruction of insulin producing cells of the body. And so, in other words, it is not a disease of lifestyle. It is not correlated with obesity. And it's not correlated, as we know it today, with the things that you eat. It's not correlated with activity or lack of activity. It is tied to certain genetic markers that you inherit and it's correlated to exposure to certain triggers in the environment that can make those genetic markers cause an autoimmune response. Now, some of those, the triggers are vast that we understand. Some of them are viruses. Some of those things are pollutants that we can't sort of, avoid. So there are a lot of triggers that go into type 1 diabetes. But the bottom line is that the sort of pathophysiology, the cause and then pathophysiology of type 1 diabetes is very different. Type 1 diabetics tend to be fully reliant on insulin. They have to inject insulin in order to regulate blood glucose because they themselves don't produce much or any glucose, or any insulin, right? So they're dependent on insulin. Type 2 diabetics, more often than not, they're not dependent on insulin unless the disease becomes really bad. Type 2 diabetics can regulate blood sugar based on lifestyle changes, right? They can they can do the reversal, and they can reverse their symptomology. Type 2 diabetics can simply by exercising more, being more active, and changing their diet. Whereas type 1 diabetics, there's no such thing as that. They're going to be monitoring their blood glucose continuously, basically for life. They're going to learn how complicated the effect of exercise is on their personal blood glucose control, blood glucose control, and they'll be reliant on insulin as well. And then one last thing I'll mention in terms of the difference between type 1 and type 2 diabetes is the effect of exercise on each of them is different. It is different. Whereas what we typically see is that like exercise duration and intensity is kind of a good thing for type 2 diabetics. It's kind of a good thing for blood glucose control ultimately. For type 1 diabetics, it can be very troublesome to sort of like understand the effects of exercise intensity and duration on blood glucose. I have a student right now who was just telling me that every time he exercises high intensity, he becomes super hyperglycemic. So his blood sugar skyrockets, and then it's very difficult for him to pull it back down. And so it becomes very difficult to tell different diabetic folks what to do. Type 1 diabetics, you tell them one thing, but the opposite might hold true for somebody with type 2 diabetes. So there's a lot of complexity there. I'm going to stop talking. I think I talked too long. That is usually the case.
No, you're all good. We love it. So real quick, Ryan had a question in the chat asking, can you fix type 1 diabetes with a pancreas transplant since the person will be on immunosuppressants anyway?
They do. I don't know about whole pancreatic transplants. They do beta cell transplants. So if you look at the pancreas as an organ, the pancreas is really fucking sweet because the pancreas is involved with digestion of nutrients, and it's also involved in regulation of blood sugar and some other things. But the part of the pancreas that regulates digestion of nutrients is not always like fucked up in type 1 diabetes. The part that is endocrine in nature, the part that produces insulin and the part that produces glucagon, in other words, the type of cells of the pancreas that are endocrine, those are called the beta cells and the alpha cells. And those cells are usually under attack by the immune system. And there is data showing the effect of beta cell, specific beta cell transplantation and how it can improve insulin control, glucose control rather, in type 1 diabetics. I'm not super up on like whole body transplantation for type 1 diabetes, so I can't speak to that element.
Thank you for answering that to the best of your capability, though. Real quick, so since Dr. Schick, you're speaking on how exercise has different effects on type 1 and type 2 diabetes, Dr. Escobar, would you like to kind of touch on how different types of exercise may affect one or the other and how certain exercise may benefit a type 2 diabetic versus a type 1?
Yeah, sure. The biggest thing is, well, this goes for pretty much anything in our field when you're going to apply it, is it depends and it varies on individual. So, when you when we're reading textbooks or talking about things in class or in lecture, we kind of talk about averages or average responses or mean responses. But the key thing to keep in context with that is there are individual differences, and those individual differences can be pretty significant. So it really just depends on, sure, the type of diabetes, but it also depends on that individual person, right? But the couple of things that you would want to for sure keep in mind are, what are the blood glucose response to different types of exercise, right? Because if you understand that, then you know what sort of blood glucose response to expect, what precautions you might take, what contingencies you might have, and what sort of exercises you might do with an individual versus not doing with an individual. And depending on what their blood glucose is that day, right? Or if it changes during the exercise, what you need to alter, right? So, particularly with type 2 diabetes, if they're coming in with incredibly high blood glucose, you generally don't want to do exercise. Like the ACSM sort of guidelines are, you don't have to remember this right now, but 250 is it deciliters per liter. What is the unit, Schick? I forget. Deciliters per milliliter.
I think it's is it milligrams per? I think it's milligrams per deciliter.
Milligrams per deciliter. That's right.
Because they don't do it in millimolar, right? I don't think they do.
No.
Yeah.
So if they come in too high, then you generally don't want to do exercise, right? 250, 300, depending if they're ketones or not, right? And the individuals that have diagnosed diabetes, either type 1 or type 2, they're most likely going to have glucometers, right? They're gonna monitor it. And so you want to rely on them to be consistent with it, to be on top of it, and to be able to take it if they need to. So when I'm working with a client, I have one right now, it's not too uncontrolled, but largely that's because they're on a number of medications and they've been exercising with me for a pretty extended period of time. So it's gotten better, but it's managed because of the medication, right? And another thing, if they change medications, you also want to keep that in mind and note that, because that might alter their blood glucose response. Okay. So, perfect example is the client that I'm working with now. Usually doesn't have too much big swings during the day or during our exercise. But I'll ask him, okay, hey, what's your glucose right now? Right. Or within the last half an hour or so. Okay. He'll tell me. I'll say, okay, what time did you eat? What did you eat? What was it when you woke up this morning? So it gives me an idea of not just what the glucose numbers are at this moment, but what has caused them. Because if they ate right before, then guess what? Glucose is going to trend up as it gets digested and being released into the bloodstream. So you'll want to monitor what their glucose is coming in. You'll want to monitor during the exercise, especially if it's a longer session. You'll want to check in with them on how they're feeling. They'll pretty much know. And another thing is you really want to have a good sort of rapport and communication lines with them so that they'll know how they feel, right? Or some people, they'll be sort of stubborn about it, and you'll have to ask them multiple times, like, no, let's check it. No, let's check it. No, I'm fine. No, let's check it, right? So everyone's a little bit different. And then the other thing too is post-exercise, we'll check it right after. And then I train his wife for 30 minutes. And then before they leave, I'll have them check it again. So I have an idea of where he was at, where he finished. And then over the 30 minutes, are we seeing a nice decline like we kind of want to see, right? But not too low of a decline. Because one of the things that happens is, let's go back to where I was going to start with, was the exercise response, right? So if you are going to engage in exercise, particularly higher types of intensity exercise, which, within every individual, it's going to vary, right? something that might be easy for us might be more intense for an older individual, right, or untrained individual. So if it's a more demanding type of exercise, that is going to elicit an increase in blood glucose. Okay, so that's another thing that you want to tell them as well, because if we check it during exercise or after exercise and it's up 20, 30 points or more, they might freak out, but you have to tell them, no, this is a normal response. Okay, as long as, the next 15, 20, 30 minutes, 60 minutes that we see it start to come down, that's okay, right? So you have to give them an idea of what to expect so they don't freak out and they're informed, right? And the other thing too is when they are, say they have their little app or the little glucometer, they can add notes. It's like, hey, you need to write down that this spike in blood glucose and blood sugar was from exercise and not because you're sneaking ice cream, right? So your doctor knows that. Okay, so there's a big difference, right? Now, if you're doing more lower intensity exercise, again, it's going to vary. Generally, you're going to see a little bit of not a little bit, you could see a drop. Okay, now you might get a little bit of a increase at first, and then it'll start to decline, right? But generally speaking, higher intensity exercise, you'll have an increase. Lower intensity exercise, you'll have a decrease, right? And the reason for that is because higher intensity exercise is going to elicit a pretty strong catecholamine response, which is going to act to release glucose into the bloodstream, right? So even with my client that I work with now, he'll wake up, check his sugar, and it's, something, and then he'll get up, walk around, take a shower, and then it's, 20, 30, 40 points above because he just got up and was more active, right? So you had that catecholamine response that acted to increase blood sugar. Okay. The other thing that you want to sort of keep an eye out for is the post-exercise hypoglycemic response, right? Because one of the things that happens with exercise is it increases insulin-independent glucose uptake. So just the contraction of the muscles itself through AMPK, which we talk about in class, and I'm sure you talk about with Schick as well. But you have an increase in GLUT4 transporters, and that is going to uptake glucose out of the blood and into the muscle cell, right? And so with that response, okay, you can have a large or significant uptake of sugar, of glucose out of the bloodstream into the muscle post-exercise, and it could take too much out of the blood, and you can go hypoglycemic. So the one thing that I'll tell my client now is, check it in another 20, 30 minutes, right? Check it in another hour. Especially if we see from the immediately post to 30 minutes post, if we see a very sharp decline, say, hey, just keep an eye on, right? So that's one thing you want to keep in mind if you're working with one of these individuals. And then just one little bit on, say, working with a type 1 person with type 1 diabetes, which I've worked with in the past. And this is it's not necessarily exclusive to type 1 individuals, type 1 diabetes, but type 2 as well. But if you're working with someone and it is pretty severe or uncontrolled, where it's advisable to not continuously monitor, but monitor regularly, okay? If you start to see a decline, which this has been the case a couple of times with a client of mine, if it starts to go down over a period of time throughout the workout, what do you got to do? Let's ease off. Let's take a break. Let's slow down the pace. Let's grab a little candy or some juice, or just alter the intensity and the pace of the session, of the workout. All right. And that in and of itself is highly individual, right? Because I was working with someone for quite a while, and once we start to see her sugar go down, it was type 1 diabetic, sugar go down, more or less, I knew what, depending on the rate of decline, I knew more or less, okay, how much to slow things down, how long to rest, right? Not always perfect, right? We always continue to measure it, but I had a good sense of like, okay, how do we alter, how do we slow things down? How do we modify what we're doing? Okay. And when to, when it is recommended to get a little candy or juice or whatnot. So, those things, the blood glucose response, pre, during, post, things like that, the response to different types of exercise is pretty huge. Having an idea of medication status, right? If they just took their insulin, probably not a good idea to exercise, because they'll have glucose being uptaken from the insulin, and then they'll have glucose being uptaken from the muscle contraction, from the muscle activity, right? So yeah, those are just a couple of things of working with individuals that might have type 1 or type 2 diabetes.
Hey, Dr. Escobar, can I ask a question?
Yeah.
Of your people that you're working with, are there any people that are showing up with continuous glucose monitors like the Dexcom?
Yeah, they've got the thing. They just take the little thing, beep it, boom. Is that is that CGM, right? Or is CGM it just continuously you're getting the read?
Yeah, yeah. So I had a student 2 years ago who was type 1, and she had a Dexcom, the continuous glucose monitor, and it's basically like she had it inserted subdurally right on her hip.
Yeah,
I think is like right where they like to do it, like right on the hip line. And so like she would just show me her monitor, and you can just see it changing in real time, just like every 5 seconds.
Yeah, you know what? Yeah, I have.
It's amazing.
Yeah.
I'm reading a couple questions here in the chat real quick. First to Josh's question on, let's say a person type 1 and type 2, let's say post-exercise, their glucose levels don't decrease. How would you go about that? And then after this, we'll go into Odie's question.
I think it would depend on how long they stay elevated, and then what the values are. If they stay, high, I don't know, 250, or I don't know, Schick, what might be a good range where, and it's going to be dependent, right, on the individual, but there's going to be a range over a period of time where, hey, it's probably a good idea to take insulin.
It's like super complicated because like type 1 diabetics usually have like multiple types of insulins that they're taking. So it's like they'll wake up and take their slow acting one, and then they'll layer that with like a fast acting one. And so sometimes it's like the trainer's responsibility to be like, hold off on the fast acting one for like the next hour, take like the long acting one. So it's really complicated as far as a range. I don't know. I don't know if you guys are aware, but like blood glucose ranges are massive. Like you can have a blood glucose value of 0, like absolute 0. And you can have it as high as like 900, I think it is, something like that. So
yeah, I think that's going to be dependent on what their physician probably says. At this number, this is when you need to take like either, some sort of insulin. My client that has type 2 diabetes, he's got 3 different types and metformin, right? And they just changed it to Trulicity. And the other thing too is, depending on the client, they might not have a very sophisticated understanding of what's going on inside the body, and you might not get perfect information from them. And so if there is, another person that you can be in contact with that might be able to communicate the status of things better, that's, communicate with them. If you can ask for, some documentation to get some information, because again, you talk to people, oh no, they gave me this, they gave me that, I take it this, and then, oh, how did you, like, what happened to your blood sugar? And they won't even be able to explain what happened. They're just, it's not something that's on their radar. They're not trained to, think about those things. And the other thing too is blood glucose responses to meals is completely almost like unpredictable as well, right? I'll ask him, their numbers are here. Well, what did you eat? Is like next to no carbohydrates, but it went up. Or they ate a bowl of oatmeal and it didn't go up that much, right? So it's really unpredictable. It's highly variable, and there's just a bunch of other, environmental, lifestyle, timing of days, sort of thing that it's really hard. It's hard to predict or expect specific blood glucose responses, right? But you want to have as good of an understanding as you can with that individual, given all that variability, right?
I think that point is a massive, massive point that Dr. Escobar is driving at. The sheer non-textbook blood glucose response to foods. You know, we're all shown the glycemic index, and that if you eat pure, like hardcore unprocessed grains, then your blood glucose like won't go up according to the glycemic index. And if you eat like Wonder Bread, like, you know, straight white bread, it's going to spike. And then like in reality, you take those two things and you eat them, 9 times out of 10, they have the same fucking effect. So like, what do we tell people? What's the real answer here? Where you're seeing one thing in a textbook versus a real life thing. You realize how complex everything in your life is and how complex your body is. And I mean, I get that question all the time, is what type of bread should I be eating? What type of pasta should I be eating? I get such specific questions about things. Should I eat an apple or a banana? I mean, you can drive yourself mad thinking about it. The experience that I have, and it sounds like with Dr. Escobar too, is that no response is ever textbook, ever. You can become severely hyperglycemic from a bowl of fucking oats, and you can have your blood glucose totally flat in response to a Twix bar. It happens, and there's a million reasons why. And ultimately, a lot of times we don't know why. That's just the way it happens.
And you know, the glycemic index is standardized to you know, a slice of white bread, or like a serving of white bread, right? And who eats just white bread by itself unless you're drunk?
Definitely, I feel you guys on that. Kind of on the topic of diet and food intake, Odie's question here is concerning both type 2 diabetes and gestational diabetes. We know that neither of you guys are dietitians or nutritionists, but in your own mind, if a person's having a problem with glucose, would you recommend them a lower carb diet, as there would be less glucose most likely? Odie's saying that we talked about substrate usage in class, and so if somebody eats less carbs, they might diminish their ability to utilize carbs as well. So like if a client were to ask you what should they change, if they should lower their carb intake, what is your kind of response to that question for both type 2 diabetes and gestational?
You or me first?
We'll go Dr. Escobar first.
Okay. Yeah, you know, again, going to the reality to what's stated in the textbooks. Okay, this is a perfect example of that. You know, I made this point, I said this in class, it might have been in 405, yes, this week or the week before, right? We're talking about different types of diet and whatnot. Proportionally, or in terms of magnitude of impact, it's way less important to focus on what specific foods you're eating versus just being more active. And if you have weight to lose, losing some weight, because that in and of itself is going to have a pretty robust effect on blood glucose regulation. So I would say, from a practical recommendation standpoint, I would say that is at near the top, right? Now, from maybe a meal to meal sort of basis, again, it's really, really going to vary, because again, I think of my client and I just ask them, hey, what'd you eat for breakfast? What'd you eat for dinner last night? What'd that do to your blood glucose? And it's like, literally, there's no correlation between food and blood glucose response, you know. But you know, the one thing I would say is, to the extent that the individual can, or is willing to, or is willing and able to get an idea how they respond to certain types of foods, because the responses, even though they vary, right? If you can get sort of like an individual profile, okay, if I eat this much of it, this is what happens to my blood glucose on average, right? because yeah, with individuals that do have diabetes, either one or two, you don't want to have huge swings in glucose up or down, right? So there is a focus or a priority on keeping it in certain ranges, so I know the textbooks and the RD and the dietetics will say whole grains and that sort of thing, low glycemic, but it's just so variable that I would say, just again, we're not nutritionists or dietitians, but the impact on exercise and losing weight, that is going to have a big impact on blood glucose regulation. And then also, just finding foods that mitigate huge swings in blood glucose levels.
I'm glad Dr. Escobar went first because he said something better than I would have said. I agree. It's so highly individualized to the point that, like, when I'm asked this question, that my response is usually track yourself for 5 days, download MyFitnessPal, track everything you're eating so that you know where you're actually at, and then we can go over your results. The majority of people, don't need massively high carbohydrate diets, and they could probably do with a little bit more protein. So in general, just a very generic answer would be everything that Dr. Escobar said, and then I'll add that you got to track what you're eating so that you know where you're actually at, because you may not actually need to change anything. Who knows? So you need to know where you're at before you make any recommendation. And in general, a controlled carbohydrate diet and with a decent amount of protein is always good for the majority of us. And on top of that, big area of research right now, and Dr. Escobar and I just sent 2 students to do their PhD at UAB to study this, is the effect of your gut on glycemic control. So on top of, prescribing macronutrient balance, how about prescribing probiotic food? So things that are fermented, so yogurts and kimchi and sauerkraut on top of, an actual probiotic type of supplement is probably beneficial to just about all of us, because we're just beginning to understand how heavily your gut plays a role in regulating glycemic control, because your gut produces its own hormones that affect your pancreas's ability to secrete and use insulin.
There are more bacteria in our gut and bodies than our own cells. So who really are we?
I'm a disgusting germ.
Exactly. We're all feeling like that, especially coming to the 6th season coming in. But so a question that I had from a little bit ago, that you guys were speaking on how fitness kind of affects everything. So when it comes to pre-diabetes, when it, like, obviously they would be either going into type 2 diabetes or possibly gestational. I'm big on the mindset of a prehab, so just any type of preemptive care. So is there certain things you would recommend, maybe more so like cardio exercise or strength conditioning, things like along that nature, to combat a pre-diabetic person who's trying to not become diabetic?
Less video games.
Exactly. So like less of that sedentary lifestyle. All right. So right.
I can add just a little bit
Yeah.
to that. Muscle contraction is muscle contraction, and that is going to stimulate 2 things. It's going to stimulate an increase in insulin independent glucose uptake, like I mentioned, but then also what it's going to do, this is in the acute standpoint, it's also going to increase insulin sensitivity for, I believe, depending on the intensity and the volume of the training session, like 48 hours, up to 48 hours, Dr. Schick? Yeah. So that's a really big deal, right? Because if you have someone that has trouble regulating their blood glucose, whether it's pre-diabetes, if it's close to that threshold, just by engaging in regular activity, that's going to take glucose out of the blood. So bring their numbers down. That's going to increase their sensitivity to insulin. So they respond better to the insulin signal. That's going to help keep their numbers down, right? And then that's the acute standpoint. From a long-term standpoint, the chronic standpoint, you get an increased amount of GLUT4 transporters, so more of the channels, the proteins that get glucose out of the blood into the muscle. And then you also get long-term increased insulin sensitivity. So just baseline sensitivity to insulin signaling. And then there's one more thing I was going to say. And losing some weight if there is some adiposity to lose, that makes a big difference. So the other thing, when you train, when you exercise, it's specific to that musculature trained. So meaning if you do a leg day, a lower body day, that is going to have a greater effect on insulin sensitivity and glucose uptake than doing shrugs, right? Because there's just more musculature being trained, so that response is occurring in more tissues compared to the shrugs. That's why I do my shrugs on leg day.
I was just going to say, what he's not saying is to not do shrugs. He's just saying be creative. Be creative and maybe do a high volume load of shrugs. Don't just do a few sets, do millions of sets. That's I just want to be clear on that. Yeah, I second everything that Dr. Escobar said. It's unfortunately, it's sort of confoundingly and infuriatingly simple to an extent, which is that you gotta, it's that thing of like taking the stairs instead of the elevator when you can. It's standing sometimes instead of sitting. It's not just thinking that 30 minutes of intense exercise in the morning is enough activity throughout the day to engage your system. It's a thing of being consistently active and consistently making better food choices. Which is something I struggle with. But it's not that you have to go to In-N-Out every single day. You can go In-N-Out once a week. And the other days of the week you can eat decently.
Yeah,
how about you all do Ryan's recommendation? How about that? We would love watching that.
Yeah, I'm starting to put on the winter coat, so I might have to start doing that anyways. But yeah, I wanted to kind of open the floor right now to anybody if you have any clarification questions or questions specifically, but like if you heard any words or phrases that you don't quite understand or comprehend, please ask right now. If you can't think of it right now, you can always reach out to us through our Instagram and we'll try to get you the best answer possible. But yeah, if anyone has any questions right now, you can raise your hand or type it in the chat. I'll give you a second to get that together. Yeah, a good recommendation from Odie right there. Just start doing squats while in lecture.
Just have you do wall squats, just like put your back against the wall the whole time.
Exactly.
Am I allowed to do that next class, Dr. Escobar?
Valenzuela had them doing squats in their class apparently. But yeah, so if no one has any like clarifying questions right now, Dr. Escobar or Aaron, did you?
Yeah.
All right. So
I had a question. I kind of addicted to energy drinks, so I switched to one with sucralose or artificial sweeteners. So I was just wondering, in terms of artificial sweeteners, I've read stuff that I think Dr. Schick spoke on it, where it changes the microbiome and maybe that leads to insulin resistance. So I was just wondering if you guys have any thoughts or ideas on artificial sweeteners as it relates to
minimize it when you can. Minimize artificial sweeteners while you can. I had a student who did research a couple years ago looking at artificial sweetener, and man, it fucks you up. It screws up your gut microbiome pretty much top to bottom. It's also, in some cases, it can act almost like a neurotoxin and can screw up certain neural structures, and it has weird cognitive effects. And it also artificial sweetener isn't sugar. So on top of all that stuff, the good thing about sugar, like real sugar, is that it stimulates your hypothalamus through the action of leptin to make you feel full, so that like you stop eating. That's actually a good thing that like real sugar does, is it stimulates leptin release from fat cells, and leptin targets your hypothalamus and provides you the satiety signal. Artificial sweetener tastes like sugar, but it fools your brain into thinking that you're not full because it doesn't send a satiety signal. And so like sucralose and aspartame, and there are a few other insulters, they taste sweet, but they don't make you feel full. So like you'll just want to keep eating. And so when, you know, and I always find it funny. I know this isn't like exactly what you asked, Aaron, but like I'm guilty of this, is that like going to In-N-Out and getting like a 4x4 chocolate shake, cheese fries, and then a Diet Coke, because that's going to save me. I want to save that extra 200 calories, you know, because everything else was a problem. That doesn't do anything for you. You know, in fact, if I had a real sugar soda, maybe it would prevent me from finishing the chocolate shake or the cheese fries. You know what I mean? So artificial sweeteners, on top of screwing up your gut health, on top of potentially screwing up brain function and not sparking a satiety, a feeling of satiety, they're also sort of useless for diet. They're useless for dieting. Like they don't do anything positive. There's also evidence to show that certain artificial sweeteners can negatively influence beta cell function. I was turned on to that research a few years ago from a student, where artificial sweeteners can actually screw up gut hormone release. And the reason that that's important is because there are certain gut hormones like GLP-1 and GIP that stimulate insulin secretion. But artificial sweeteners, when they inhibit GLP-1 and GIP in the gut, you don't get the accelerating influence of those gut hormones on your pancreas. And so you're left with this curbed insulin effect when you have lots of sucralose, because it's screwed up your gut. Your gut communicates with your pancreas, your gut communicates with your brain, your gut communicates with everything. And sucralose screws that up.
Yeah, thank you. That answers that question pretty well for me. I hope the same for you, Aaron. But Ryan, you have a question?
Yeah. So a couple of years ago, I used to have like a big Diet Coke with lunch every day when I was at work. And I noticed that I was getting super low blood sugar, like after lunch every day. And it stopped when I started drinking regular soda, or just not having soda again. So I always thought that diet soda triggered an insulin spike, but then there was no sugar. And so you would end up hypoglycemic. And so that's why I stopped using artificial sweeteners, because I was worried. Like I almost passed out a couple of times, got really bad because I was doing it every day. Is that true? Does it trigger a big release of insulin just because your brain thinks it's sugar, or your body thinks it's sugar, but then there's no sugar, and so you just have all this insulin with nothing to do?
I think it's more the fact that you're starving yourself of calories, so you're becoming hypoglycemic.
Okay.
All right. Does anyone else have any questions or clarifications to ask?
I had a question about the response to different foods. How you said that, you know, you might do like bread instead of a Twix. Could you explain some of the reasons why that might be, or some of the thoughts behind that? Because you guys said that there's like so many reasons why. I'm just wondering if there's any that you think might be the most probable.
I couldn't hear like the whole question, but it was in response to, I think I said that, right? Odie?
Yeah.
Yeah. Why is blood glucose response sometimes unpredictable? and sort of like counter to what you would expect? Is that the question?
Yeah.
Yeah, one of his specific references was the Twix to bread reference.
What
It's
when I
mul-
googled it, a response came out saying it's about the microbiome, kind of what you're saying about the gut health.
Yeah, it's multifactorial. And to be honest, I can't even answer that question fully because I don't super know. What I do know is that we see in many cases a highly individualized blood glucose response to various foods, the type of response that isn't predictable. And there could be lots of reasons for it. It could be a lack of gut health. It could be that maybe you're acutely sick. Maybe you just exercised, and so you were expecting some response, but it didn't come because you forgot that you exercised. Maybe it's because you didn't exercise like you usually do, yet you ate the same food. Maybe it's because you got a lack of sleep. Distress caused by lack of sleep is astounding, guys. You should look at research on adiposity and stress in response to lack of sleep. As somebody who never sleeps, I can tell you that it causes all sorts of emotional problems. And so, there's like a lot of things. I'm sorry, that's probably not a satisfactory response, but that's my response.
It was helpful. Thank you.
It's extremely appreciative when you guys are able to say like you don't know the answer to a question, or like this is a very generalized question to something, or answer to something that we're questioning. I mean, it's appreciative because there's so much like misinformation, and our club, we try to be as much research oriented as possible. So with you guys saying that, it's highly appreciated. But kind of moving on, Josh has a question here in the chat, asking how much of an effect does socioeconomic status play on diet nowadays. He knows that we touched on diets in our society, but as exercise professionals, how can we help with this issue? If one of you want to, or Dr. Escobar, if you want to take that question.
Yeah, it plays a huge role, right? And so from like a practical, strategic, physiological standpoint, we know what would help these problems, what would prevent it, what would manage it, what would reverse these types of conditions, right? But the reality is people come from different circumstances where, in one context, it might be completely advisable and wise to say, hey, after you eat dinner, go out for a walk in your neighborhood. Some people, you don't want to go out and walk in your neighborhood. I wouldn't want my grandma walking out at night in her neighborhood, right? So it plays a big role. The other thing too is, and I mentioned a little bit of this in 405, like my family history, my grandparents on my mom's side, they came from Mexico. They were poor. They worked in the fields their entire lives. My mom lived in a house with dirt floors for some time as she worked in the fields. And, they struggled their entire life. And my grandpa, I mentioned him in class, didn't have food growing up, right? And now they come here and they're doing well by their standards because they're not starving anymore, right? But they came here and he was no longer hungry. He had food. And so because he never got to eat the things that he wanted to eat or have enough food, guess what? He ate what he wanted to eat, and he ate as much as he wanted because he never could do that before in his life. And so he got diabetes, right? And he had some other chronic conditions that had to do with, not strictly lifestyle, but other things that the diabetes and blood pressure and cholesterol like clearly compounded into affecting his health negatively, right? And my mom became health conscious, and as we got older, they tell my grandpa, who was in and out of the hospital with diabetes and other complications and stuff like that, it's like, hey, you gotta, the doctor would tell him, you gotta eat vegetables. Like, don't just eat, refried beans and tortillas and all of the good stuff, right? You should eat more vegetables. And he would say in Spanish, like, why would I eat vegetables? I'm not a rabbit, right? And then he would say, the doctor would tell him, hey, you need to walk. And so what he would do, he would like split the difference. He'd go walk, but he walked to Burger King. Okay. So it's better than driving to Burger King. But, just I am intimately aware of the socioeconomic impacts and barriers and the accessibility or even the knowledge, right? Individuals that may not have, may not be of high socioeconomic status or educational status, like they're not thinking about these things. That's not something that is on their day to day, right? They don't have a reference on their radar for them. And it is a challenge. And the other thing too, and I'm, kind of complicit in this, is I'm working in the health field. Well, guess what? A lot of people can't afford this. Right? Only people that have a certain amount of means can afford to be doing this type of thing. Again, this sort of help and education and work, right? So, it's a challenging thing. The I guess, like, speaking on the way I sort of approach it is try to communicate things and as most I don't say simplistic, but communicate things in a way that certain types of people will understand, right? To the best that you can, because sometimes there are sort of cultural divides and whatnot, right? But yeah, trying to communicate, try to provide some sort of education, and then trying to provide some sort of strategies that might be necessary in some contexts with some demographics that don't even need to be considered in others, right? Things like that. So it definitely is a complicated thing. But as exercise, fitness, health minded professionals, right, we at least have the ability to help those in our family and those in our social circle, and they don't got to write us a check for that, right? Because we're family. So, yeah.
Yeah, thank you for the personal stories and sharing your personal family history with us. That's pretty great answer to that question. I can have answered that better myself in any capacity. I'm kind of relating to you on my family as well, with like my great grandpa lived to 100, like fully healthy, mobile his entire life. Mostly refried beans and tortillas every day, but like at the end of every day, he'd have like a couple Serranos. But also have that with a couple of beers. So now I've kind of enacted the Serranos in my own diet. So it's big on might not be able to get our hands on a lot of things that are necessary tools or food for our everyday health and kind of bettering our health and heart health and everything. But maybe a Serrano or two a day might help you in the long run. But yeah, with anybody else, did you have any other questions or clarifications that you wanted to ask? All right. So kind of winding down now, for those of you that don't know, or maybe this is your first meeting with us, we're IMOC, we're Exercises Medicine on Campus. We're a global initiative organization that is big on the mindset of exercise on a daily basis will in turn have a positive effect on all types of health, going from mental, physical, psychological. This is something that we're trying to enact in our campus every single day and with every single event, especially with our Q&A events like these, highly informational on things like diabetes, especially during the awareness months. Like last month, we had, or 2 months ago on World Heart Day, like on 9/29, we had a doctor come in and speak on heart health and exercise. So whenever we do have these Q&A kind of forum events, these are highly informational and you can ask your personal questions and even make some relations with some of our professors on campus, which is we want a bigger family culture in this healthy mindset lifestyle. So I just want to say appreciate everybody that did come today, and especially Dr. Escobar and Dr. Schick. You guys have done events for us in the past and hopefully more in the future, but you guys are awesome. And I love the informality from you guys. It makes a very comfortable environment for us to ask questions and kind of just take all the information in. So a quick round of applause for both of the doctors here today. We appreciate you guys greatly. But kind of leaving it up to you guys if you guys want to make any closing remarks. But yeah, we're coming to the end here.
No, thanks for having us. And yeah, we'd like to, this is good. That's all I gotta say.
Yeah, thanks, guys. This is great. It's always great. This is the only part of our job that we enjoy. Trust me.
Yeah, we love to hear that. We appreciate having you guys. For the board members, if you guys want to just stay back, but everyone else, you're free to go, and appreciate you guys all, and hope you have a great rest of your day and week. Cheers. All right, Osborne, you can stop the recording now.